Right, tēnā koutou katoa, and welcome to part one of our two-part webinar series with Dr. Nikki Tugnett. We are exploring medication for inflammatory arthritis in Aotearoa, and we're looking at oral disease-modifying anti-rheumatic drugs, DMARDs. And in part two, we'll cover the biological DMARDs. So tonight with us, we've got Dr. Nikki Tugnett. She's a UK-trained and New Zealand registered rheumatologist practicing in Auckland. She's also the world's first dually trained rheumatologist and yoga medicine therapeutic specialist. And this year, Dr. Nikki made a dream of hers come true by founding her own private holistic rheumatology clinic called Integrated Rheumatology. And Dr. Nikki has worked with us in the past and showcased her yoga knowledge in the form of an educational webinar about managing pain with yoga. And then she held an online chair yoga class for beginners and for those with limited mobility, which was a hit. We're so pleased to have her back to share her clinical expertise and answer your questions about medications for inflammatory arthritis. So thank you, Dr. Nikki, over to you.
Kira, thank you so much, Tracy. It's really nice to come back, and it's nice to actually come back in a slightly more clinical capacity to talk with you this evening. So I'm always wearing my hat of yoga, but primarily I'm wearing my rheumatology hat today. So over the next few weeks, we'll be exploring the different medications available for inflammatory arthritis in Aotearoa, New Zealand. And as Tracy mentioned, I'm a rheumatologist and I'm also a yoga therapist. And I like to bring both together in order to help people holistically. I'm going to preface just by giving a brief disclosure. I am a rheumatologist in public and private practice in Auckland, but my views are my own and they don't reflect those of any company or any association in New Zealand. My views are based on training, they're based on research and education, and the content that I'm providing is purely for your educational purposes. It is not meant to be direct medical advice about your particular situation. And as always, if you are actually experiencing issues related to the medications, please do talk to your own healthcare specialist, let them know what's going on. So now that we've got that out of the way, what are we going to be discussing today? So in general, we'll be talking about the classical or conventional disease-modifying anti-rheumatic drugs, or DMARDs. And on our next talk, we'll talk about the biological DMARDs. The objective is to give you a brief overview of what inflammatory arthritis is and who this talk really does apply to, and then go through some of the commonly used medications for these arthritis types, and also maybe touch on some of the future therapies that may come out. But the most important part is to give you time to ask questions at the end. So I'm really sorry to be disappointing, just in case you're looking for this, but this is what we can't discuss today. There is a lot of interest, including in myself, I have this interest in complementary therapies, including vitamins and supplements. And of course, CBD and low-dose naltrexone are often asked about, but we can't go into that today. Each of those topics would probably need a separate talk. In the interest of time, we're going to keep this a little bit brief and focused just on conventional DMARDs. And as mentioned, I can't give you personal advice as to whether you should stop or start a medication. So please do discuss that with your doctor. Everything that I say is general. Please remember that you are unique, your body is unique, your experience of arthritis is unique. And so although I'm giving you general advice and general guidelines based on evidence, it may not necessarily apply to you. And that's where your specialist or your doctor is important. So what do we mean by inflammatory arthritis? There's about 140 different types of arthritis, and most people don't have an inflammatory arthritis. They've got osteoarthritis, which is something that happens to most of us as we get a little older. And inflammatory arthritis describes a bunch of different diseases that are due to an overactive immune system. So we call them autoimmune. And common symptoms of these types of arthritis are joint pain and stiffness, soft tissue swelling. But because they're autoimmune, they're systemic, which means you can often get symptoms far away from your joints. You can feel really fatigued. You might get inflammation in other organs like your eyes or bowels, skin rashes, lung inflammation, depending on the type of arthritis that you've got. So some of the common inflammatory arthritis that we see are rheumatoid arthritis, RA, psoriatic arthritis, PSA, ankylosing spondylitis, AS, spondyloarthropathy, SPA, which is related to ankylosing spondylitis, and juvenile idiopathic arthritis, JIA. Now, inflammatory arthritis kind of suggests that there's inflammation in the person's body. And so technically, gout could be considered and is considered inflammatory arthritis. But gout is not considered to be autoimmune. So for today, we're not really referring to those conditions on the right-hand side of the screen. So we're not talking about gout. We're not talking about osteoarthritis or fibromyalgia. And we're not talking about the type of arthritis that develops after you've had an infection, such as with COVID-19. I think a more useful term is autoimmune inflammatory arthritis. And that helps us to understand that these are a bunch of different diseases affecting all ages, whether you're a baby or elderly, and where the immune system is overactive and causing the body to mistakenly attack itself. So when you live with an inflammatory autoimmune arthritis, there are multiple effects on the body and on the mind. Firstly, there's the effects of the disease itself. Now, rheumatoid is different to psoriatic, and that's different to ankylosing spondylitis, and that's different to other forms of autoimmune arthritis. But what they all tend to have in common is that if they're left untreated and the inflammation isn't controlled, it can lead to joint damage and disability. Fatigue is incredibly common. And as I mentioned, sometimes other organs can be involved. So for example, rheumatoid arthritis, about 20% of people have lung inflammation or lung scarring. It's really quite common. Living with any chronic illness is going to affect one's emotional and mental well-being. And it's increasingly noted that anxiety and depression is more common when you're living with an arthritis, as well as financial stresses. And that might be because of the cost of hospital visits or seeing a healthcare professional, or it may be prescription charges, medication charges, but also it may be because work is affected and perhaps you can't work anymore, and that's incredibly quite common. When you're first diagnosed with an inflammatory arthritis, it can be a quite lonely time, it can be an isolating time, and it can feel really overwhelming. And so it's really helpful to connect with other people, like through Arthritis New Zealand, especially people who have gone through or who are going through what you're going through, and who can help you adjust and get better. Then there are the specific effects to children who live with autoimmune inflammatory arthritis. So potentially they can become restricted with regards to their growth, their height, their weight. And of course they can miss school days, and that can affect their education. Secondly, there's the effects of the treatment. And that could be minor side effects. It could be major side effects. It could be cost. It could be difficult to access certain medications, depending on funding restrictions. It might be difficult to access a rheumatologist, depending on which part of New Zealand you live in. So all of these can create their own issues. And specifically for women who are of childbearing age, there are some medications for which pregnancy and breastfeeding are not recommended, and we'll talk about that. So we're focusing on the conventional oral disease-modifying medications, the DMARDs. And DMARDs, like all DMARDs, are not just simply painkillers. They are there to prevent damage to your joints and to reduce the inflammation, to prevent disability, to keep you enjoying a good quality of life. Methotrexate, sulfasalazine, hydroxychloroquine, and leflunomide are the most common DMARDs. But I am just going to touch on prednisone and upadacitinib because they're both taken orally, although technically they're not DMARDs. So, prednisone, also known as steroids. Most of us have a love-hate relationship with them, and most of us worry when we have to go on to steroids, very understandably. But steroids are really well researched in inflammatory arthritis, and actually in general, in autoimmune diseases in general. They really do have a role to play. There is very few medications that work as quickly as steroids do to control inflammation because they work through multiple different immune pathways. So within days of taking steroids, you can feel much better. Nowadays, we tend to use steroids as bridging therapy, so short term, and that might be for a few days, weeks, or months, in order for your long-term treatment to kick in and to actually work. Now, there are some people who've got very aggressive inflammatory arthritis, and they do need to be on regular steroids, whether that's orally or they need to have steroid injections. And whenever that decision is agreed upon, it's usually because or it always is, because the benefits of the medication outweigh the risks. So yes, we acknowledge that there are lots of potential side effects, but despite that, they are still really important for treating autoimmune conditions, especially inflammatory arthritis, and especially when you're newly diagnosed or if you're having a flare, because they work so fast to get you feeling better. Now, thankfully, we don't have to use them as much today as we used to 20 years ago, because we've got all these other DMARD medications. Now, when I talk to my patients about steroids, most people feel a bit overwhelmed when they go on to Dr. Google and have a look at potential side effects. And, it is quite scary. It is quite scary when you have a look through the information on this. But I will say that most of these potential side effects tend to occur in people who are on steroids long term, and particularly if you're in a higher dose. So the risk of getting side effects definitely is increased by the dose you're taking. So being on 2 milligrams of prednisone a day is quite a different risk profile to somebody who's taking 10 milligrams a day, or somebody who's taking 20 milligrams a day. Common side effects that my patients mention to me would be sleep disturbance. So sometimes you can feel quite wired, you can feel quite energized, and that could be a good thing, but equally it could affect your sleep. So always take steroids in the morning and never at night. It can disturb your sleep-wake cycle. Sometimes it can affect your mood as well. And of course, it can increase your appetite, and it increases your body's tendency to hold on to fatty tissue, unfortunately. So that can lead to weight gain. There are increased risks of infections when you're taking steroids. And in fact, for most of the medications that we'll be talking about tonight and in 2 weeks' time, there are slightly increased risks because you're taking a medication that's working on the immune system. Sometimes there are insufficient responses to vaccines when you're taking steroids, or slightly muted responses to vaccines. So your body might not produce that level of antibody response that we would hope for if you're taking steroids. And again, that's more likely if you're on a bigger dose. If you're diabetic or pre-diabetic, you might want to monitor your blood sugars when you take steroids, because blood glucose can go up a little. Now, in the longer term, if you're taking steroids for many months, then the risks of things like high blood pressure, fluid retention, low bone mass, cataracts, those things then can increase if we're taking these medications for months to years. But in the short term, I would say that weight gain, mood changes, sleep, and perhaps sometimes gastric side effects tend to be the most frequent. Not necessarily gastric ulcers, but heartburn and acid. So coming specifically to DMARDs. Now, methotrexate is by far the most commonly prescribed and a very widely available medication for inflammatory arthritis in New Zealand. And there's a reason for that. It's well researched. I think it was recognized in the 1950s that it's really effective for autoimmune conditions. But it is the medication that a lot of people feel fearful about, because when you go onto Dr. Google, sometimes you are met with lots of information saying that methotrexate is going to make all of your hair fall out, or that it's going to cause severe nausea and vomiting. Now, that is true for people who take methotrexate to kill cancer, because in really high doses, it is a chemotherapy and it's really effective at killing off certain types of cancer. But the doses that we use are really small in rheumatology, and we will never give you high dose methotrexate. In fact, I've never seen somebody lose all their hair with methotrexate. Some people say they feel like their hair is getting thinner, and there are ways to combat that. For example, by taking folic acid, because methotrexate works in a few different ways on the immune system, but one of the ways is by inhibiting folic acid. So that's the reason we prescribe you folic acid, because it can help to reduce the incidence of side effects. So don't forget to take it. Methotrexate is given either as a tablet or as a subcutaneous injection, and it's only ever once a week. Don't take it daily. It's slow to act, like most of our DMARDs. It takes about 3 months to work, and it's usually cleared from the body by the kidneys. There are lots of cautions that we need to take. And the most important is that you have regular blood tests when you're on methotrexate, because it can affect your liver, it can affect your bone marrow. So that is where your blood cells are made, that's where your white cells are made. And so we do regular lab tests on purpose so that we can monitor you from a distance and make sure that you are on a safe amount of your medication. It's common for people to feel quite fatigued for a day or two after taking methotrexate. And often those side effects tend to get better with further doses as your body adapts. Sometimes if the side effects are really bad with the tablet, we can offer you the injection and people can find that easier to tolerate. If you drink a lot of alcohol, it's probably not a wise idea when you're taking methotrexate, and we really would recommend you reduce your alcohol intake because of the effects on the liver. And then there are certain areas or certain situations in which we don't want you to take methotrexate. So firstly, if you are pregnant or if you're thinking of becoming pregnant or you're breastfeeding, so if you are planning a pregnancy imminently, within the next year, within the next 12 months, I'd probably say, well, I would say methotrexate is probably not the way forward for you. Now, methotrexate can usually take about 3 months for you to fully eliminate it from your body when you stop taking it. So it hangs around for a while. So pregnancy and breastfeeding, not recommended because it affects not just the development of the baby, but it can unfortunately also increase the chances of a miscarriage. I've mentioned alcohol. You do need to make sure your alcohol is within safe limits so that you're not overloading your liver. And if you do actually have severe liver disease or severe kidney disease, these are times when we wouldn't use methotrexate.
I'll mention very briefly about bone marrow toxicity, including lymphoproliferative disorders. So I get asked quite frequently whether methotrexate itself can cause lymphoma, which is a type of blood cancer. And there may be a link between people who take methotrexate for many years and development of lymphoma, but it isn't very clear. And that's because if you've got an inflammatory arthritis, so specifically rheumatoid arthritis, which has been really well studied, if you've got rheumatoid arthritis, you may well be at increased risk of both heart disease and lymphoma anyway, even without the medication. So it's often difficult to know, but what we do know is that the benefits of methotrexate far outweigh the risks. And when it's taken regularly and diligently and safely, it's a very effective medication, helping more than 70% of people feel better and get their life back. Touching briefly on sulfasalazine, which is another oral DMARD, again, very old, well studied, well researched. It's taken every day. It's a fairly large orangey coloured or yellowy coloured tablet. And we tend to start on a low dose and then build up the dose slowly over the course of a month or so. Very widely available. It's cheap, it's effective. And the most important thing I want to mention about this is that it's safe in pregnancy and breastfeeding. A lot of women can worry that they need to stop all their medication if they've got rheumatoid or AS, or they've got another type of inflammatory arthritis, and then they get pregnant. Sulfasalazine is not a medication you need to stop. So do talk to your doctor if you're planning a pregnancy or if you do find yourself pregnant, but there's no reason to stop it. And in fact, there's good evidence that if you are keeping your arthritis well controlled throughout your pregnancy and you're not flaring, then you do better and baby does better after delivery as well. Sulfasalazine can sometimes reduce sperm count in men, and it's all completely reversible once you stop the medication. But of course, if you're trying to get your partner pregnant, then you might need to think about ceasing sulfasalazine with your doctor. Otherwise, in terms of common side effects, I would say it's GI, gastrointestinal. So nausea and diarrhea seem to be the biggest ones that my patients mention to me. Usually after a few weeks or with a dose adjustment, these side effects go away and it becomes a very tolerable medication. There are some really severe, but thankfully rare adverse effects. So you can get a really severe rash with sulfasalazine, and you can get severe lung inflammation and very low white cell counts. And I've seen this a couple of times. And in those people where that happens, I would say it's almost like an allergic reaction, but you've obviously wouldn't know because you've never taken sulfasalazine before. But if that happens in your case, then it's not a drug that we would retry. It is not something that gets better by reducing the dose. We would just stop it completely and not go back on it again. So sulfasalazine, methotrexate, both require regular blood tests. Plaquenil, or hydroxychloroquine, is one that does not really require regular blood tests, at least not to the extent of the other two medications. It's commonly prescribed, it's taken every day, and it's used a lot in rheumatoid arthritis and in people who may have lupus arthritis. Again, it can take up to 6 months to be effective, very widely available, and it works really well in combination with the other tablet DMARDs. So often we might have methotrexate and Plaquenil together, or we might have methotrexate and sulfasalazine together, because one tablet on its own fails to give relief to the person, so combination works better. Again, it's safe in pregnancy and breastfeeding. You do not need to stop this medication if you're trying to get pregnant or you're breastfeeding. Talk to your doctor if you're worried at all, but there's really good evidence, multiple studies. We know that this is a safe medication. Side effects are really rare in my personal experience. Nausea, diarrhea, headache, ringing in the ears, these sorts of measures or these sorts of effects generally go away with a dose reduction or temporarily ceasing the medication. Leflunomide, also known as Arava, again, very commonly used, taking about 6 months to be fully effective and taken daily every day, either 10 or 20 milligrams. Its side effect profile is really similar to methotrexate. So it does require regular lab tests. It can affect the liver. It can affect the bone marrow where the white cells and the blood cells are made. It can cause nausea and diarrhea. And a little bit separate to methotrexate, in about 10% of people, you can get weight loss and you can get a slight elevation of your blood pressure and even sometimes some tingling and numbness due to your nerves becoming involved. But thankfully, when you stop the medication, these side effects tend to disappear. Like methotrexate, we don't recommend leflunomide when you are pregnant, breastfeeding, or even if you are trying or wanting to get pregnant within 2 years. Because leflunomide is thought to have a very long half-life, it might hang around in your blood in some degree for up to 2 years. So methotrexate is eliminated within about 3 months, but definitely by 6 months, all methotrexate is gone from your body. Leflunomide hangs around for up to 2 years. So we generally wouldn't give it to you if you're planning to get pregnant or wanting to get pregnant within 2 years. Live vaccinations are to be avoided. And again, like methotrexate, excess alcohol or severe liver disease, or if you've got lung scarring, lung inflammation, these are situations where we may not necessarily prescribe it. Or if we do prescribe it, it's really based on you as an individual and speaking to all the different specialists involved in your care. We don't want to use it if you've got out of control blood pressure. So summarizing general points about these conventional DMARDs, they're thoroughly researched and we know everything really, I think, that there is to know about their safety profile and their efficacy. They've been around for 30 to 50 years. They're fully funded, they're easy to access, and they're economical. The downsides are that they're slow to work. So you need to be taking them diligently as prescribed for at least 3 to 6 months to know that if it's working for you. And often we will use these medications in combination. And that's usually because one tablet on its own isn't quite giving you that quality of life back. You need to use reliable contraception when you're using methotrexate or leflunomide because they are not compatible with a pregnancy. So reliable contraception, ideally that means something hormonal, reversible, or maybe an IUD. But again, have that discussion with your doctor. The good news is that a good 70% of people who've got inflammatory arthritis, if you take these medications as prescribed and you don't skip too many doses, that's really important. You will experience relief and the adverse effects are not too bad. So they're manageable, they're tolerable. Blood tests are really non-negotiable for your safety. So do have them done. And then finally, mentioning this more new agent, which is not really a conventional DMARD, upadacitinib, or Rinvoq, which is a lot easier to say. Now, Rinvoq is a Janus kinase inhibitor, a JAK inhibitor. So it's inhibiting one particular molecule in your immune pathway. And it's fairly new in comparison to the other drugs. Now, it's been available internationally, I think, for a good decade or so. But we got it funded in New Zealand for rheumatoid arthritis in 2021. So it's fairly new within the armory of medications that we have here. It is actually funded for psoriatic arthritis, for AS, and even for inflammatory bowel disease in other parts of the world. And I'm really hopeful that that will come here at some point. The Rinvoq, the good news about it is that it's very fast acting compared to the other DMARDs or the other oral medications. Now, there are some people who feel that it's effective within 1 month, but usually within 2 months, you will know whether it is working for you. We do give you 3 months of taking it regularly for you to kind of really figure out if it is an effective medicine. But most people do notice within 4 to 8 weeks whether it's working for them. It's taken every day, and it's used either by itself or you can combine it with the other tablet DMARDs. We do not combine it with biological DMARDs. And that's because Rinvoq is, or a good way to think of it, or this is the way I think of it, Rinvoq is a bit like an oral biologic. So biologic medications are usually injections or infusions, and Rinvoq is a tablet, which is a lot stronger generally, or more potent, more effective than methotrexate by itself. So it's in a slightly different category in between. And it's funded for rheumatoid in New Zealand if the person has tried an anti-TNF, which is a biological therapy, but it didn't work or they couldn't tolerate it. Or if you have seronegative rheumatoid arthritis and you've tried rituximab, which is another biologic, an infusion, and that didn't work or it caused side effects, then you might be eligible to try Rinvoq. In terms of common side effects, the most frequent is the increased risks of minor respiratory tract infections. So these are your coughs, your colds, your sinus issues. In general, there are increased risks of infection, and in particular shingles, I think is important to mention here. So if you're somebody who's already had shingles, let's say, and you're going to go onto this medication, I think it would be wise to get the shingles vaccination, which has just recently been funded for people with rheumatic diseases. Not everybody, but there are certain indications and certain people who can access that funding. So chat to your GP to see if you might be one of them. Up to 10% of people may get weight gain with Rinvoq. Now, similar to biologic medications, which we'll talk about more next time, we don't recommend having Rinvoq if you have got TB, because that can reactivate. So some people have what's known as latent TB or sleeping TB inside their lungs, but don't have any symptoms necessarily. When we then check you with chest x-rays and tests, blood tests, skin tests, we find out that you have got sleeping TB. And then if you go on to Rinvoq, it can wake the TB up, and of course you can get really sick with infection. So these are safety checks that need to be done before you go onto this medication. We don't have any data for the safety of Rinvoq in pregnancy or breastfeeding, so we don't recommend it. And I'll mention briefly the FDA warning about JAK inhibitors. So the FDA is the American version of pharma, who regulate the medications coming onto the market and decide whether it's available, decide who can have it and what are the indications. And they obviously have to keep a check on any safety signals as well. So there was a different JAK inhibitor. So remember, Rinvoq is a JAK inhibitor. There was a different JAK inhibitor that was studied for a few years. And people on that particular medication, they noted that there was slightly increased risks of heart-related events. So heart attacks, strokes, lung cancers, lymphomas, and blood clots in the legs or the lungs. And so because of that, the FDA, the authorities said that anybody who takes a JAK inhibitor in general, and there's about maybe 3 or 4, maybe even 5 different JAK inhibitors now available globally, anybody who takes a JAK inhibitor needs to be made aware of those particular risks. So these risks are not specific to Rinvoq. Remember, it was a different JAK inhibitor that was studied, but the feeling is that because it's the same category of drug, maybe those risks also apply to people on Rinvoq. So for that reason, when people are offered Rinvoq, we do really carefully think about who's the best candidate to have that. So, if you have somebody who's literally, had a lot of strokes, a lot of heart attacks, or you've had lung cancer, maybe that wouldn't be the best medication for you. And that's a discussion for you to have with your doctor. And finally, future directions. Now, in terms of emerging research for conventional DMARDs, I'm not really aware of any that's going on. So medications like leflunomide, methotrexate, they've been around for 30, 50 years. They're well studied. We know that they're effective. And I don't think that there's much research going on within that field for inflammatory arthritis. However, there is lots of research going on involving biological DMARDs, and that's quite widespread, whether that's RA or psoriatic or ankylosing spondylitis. I'll mention that there are a heap of other biological medications which are available internationally, which we unfortunately don't have here in New Zealand. And perhaps one day one or two or some of these will appear here. I'm aware that there is discussion going on to get Rinvoq, that's upadacitinib, Rinvoq, funded for psoriatic arthritis and for ankylosing spondylitis. So that may come within the next year or two. And we may also see other medications like guselkumab, abatacept, and Taltz coming through at some point, but I'm not aware that there are discussions ongoing yet with Pharmac for those. But I show you this slide purely to let you know that there are lots of different medications out there for inflammatory arthritis. And so I think we just have to be optimistic and hopeful that some of these will come through and become funded in the next few years. So that's our last slide. If you have specific questions that you perhaps are too shy to ask, you're always welcome to contact us. And if you have questions specifically about biological medication, join in again on the 30th of July and we'll go through that in more detail.
Thank you very much for that, Nikki. We do have a few questions popping up here. Kylie says, when you get a cold or chest infection, should you stop taking the conventional DMARD until you have recovered? She tends to get chest infections quite severely whenever she gets cold.
So I think if you're getting a chest infection, you're particularly if you're coughing up phlegm and sputum, I think it's wise to withhold your conventional DMARD until your infection's cleared. Definitely if you're having to take antibiotics.
If you find the cartilage between joints is getting thinner to where you have bone on hips and knees, would you say it is possibly inflammatory arthritis? And should you ask a doctor or surgeon to test for it?
Well, that's a little difficult because if you have an inflammatory arthritis like rheumatoid and you've had it long enough and there's been lots of inflammation, you may well develop secondary osteoarthritis. So that means your cartilage wears away and then you can end up bone on bone. So yes, it is possible. But I think in New Zealand anyway, the most common reason for bone on bone in knees is osteoarthritis without any inflammatory arthritis. So I think if you are concerned, I would start with your GP because your symptoms of inflammatory arthritis are quite different to symptoms of osteoarthritis. A clinician can generally piece together whether somebody's likely to have underlying inflammatory arthritis by talking to you. And so, GPs may do it, or maybe they'll refer you to see a rheumatologist like me.
Is methotrexate the only DMARD that causes rheumatoid nodules?
That's a good question. To my knowledge, yes, it is. Yeah, so it can increase the growth of rheumatoid nodules in people. Yeah, I have seen that happen.
Lee asks, I take Plaquenil for RA and undifferentiated connective tissue disease. The bottle says to avoid the sun. Why is that?
So in some people who take hydroxychloroquine, their skin can become a bit more sensitive to the sun. And so they may be more prone to rashes or even sunburn, or they might get hyperpigmentation. So I don't see it as a common side effect for my patients, but it does happen from time to time in some people. So that's why that is there.
Dr. Nikki, how would you find the cause for the inflammatory response? When on meds, the signs and symptoms may go away, but will surely return if the trigger hasn't been recognised, i.e. what test could you use?
I'm not sure what that means. So are we talking about trying to find out the root cause of inflammation, the root cause of autoimmunity?
Yeah, I think so, because inflammatory responses can be from lots of different things. So maybe they just mean the autoimmune inflammatory response.
Yeah. So I think that's tricky. I mean, that's a separate talk, looking at the root causes of why people develop autoimmune diseases. And you can certainly work with, a person interested in lifestyle medicine and the pillars of lifestyle medicine to try and weed out what may be the particular trigger in your case, whether that's looking at your nutrition and looking at your stress management, which I personally think is a big, big reason for certain autoimmune conditions to start when they do. So sorry, I forget what the question was. What was it again?
They said when on meds, the signs and symptoms may go away, but will surely return if the trigger hasn't been recognised.
Yeah, I'm not sure if it's about the trigger not being recognized. I think it's the nature of the beast. So I've certainly seen some patients who have really tried, they've worked hard to address nutrition, gut health, sleep, stress, all of that stuff. They've looked for other things that may have triggered their arthritis, but actually I'm not convinced that you can always identify the trigger in your case, and sometimes it's multiple triggers. And so what I would say is, if you feel better on the medication and then you get worse when you come off it, it's because I would think your medication is doing its job. It's holding things in remission or low disease activity, and then you notice when you come off it. I don't know if that answers the question, but yeah.
And would you explain it? So with like autoimmune inflammation, is that once it's turned on, and you can't necessarily turn it all the way off again?
Yeah, I would like to say that it was that simple. I think there is severe inflammatory responses that are like a switch, once they turn on, and then you give them certain medications and you turn it off. But I think if you've got a tendency to autoimmune inflammation, it's sort of always there, it's always lurking. And sometimes your particular arthritis might go into a natural remission. Your inflammation, for whatever reason, may go into a natural remission without medication. Let's say, you took medication, then you stopped it and you're still in remission. But it's not as simple as saying that you could stop the medication, address the trigger, and still stay in remission.
Peg asked, if you change to another drug, can you go back to the original drug if not working? E.g., if you change to leflunomide, can you revert back to methotrexate?
Yeah, we do that quite a lot. So as long as you were able to tolerate the first drug, yeah, you definitely can switch. And sometimes we have to do that. Sometimes a person will cycle through all of the different tablet DMARDs. Maybe they've cycled through because they got side effects, and maybe they didn't take it for that long and didn't want to keep on taking it. But then we have to come back around to it because they don't quite meet criteria to move on to a biologic medication. And sometimes when you experiment with how you take your medication, it becomes a lot more tolerable. There are some people who just love taking their methotrexate in the nighttime. There are those who prefer it in the morning. There are those who always take it on empty stomach, and there are those who don't, because they've explored and figured out that if they take it that way, they feel better.
Denise says, I've been diagnosed with RA for 59 years. After a successful many years on gold therapy, I had to stop due to crystals of gold in breast tissue. And then went on the meds you are discussing. Is there a time when the inflammatory aspects of RA burns out and you can stop the heavy meds?
Yeah, it's a great question. And I wish I could say yes. I wish I could say, yep, you're going to turn 70 or turn 60 and it all goes away. I don't unfortunately think it's that simple. So I'll give you an example. So I've got patients who are newly diagnosed with RA when they're 70, 80 years old. That's the first time they ever develop RA. So it's not an age-related phenomenon. I've got others who may have had RA since they were 18, 20 years old. And then by the time they get to menopause, it's not as active as it used to be. And they are able to really substantially reduce their medication. And I don't know necessarily what the reasons are that some people can really reduce or maybe even cease temporarily their medication, and others need to stay on it.
Can you overdose on folic acid? I noted you said taking folic acid could help with hair loss. I have got hair loss since starting methotrexate 6 years ago. Should or could I double the folic acid dosage?
Yes. So I think the standard dose is a 5 milligram tablet once a week in New Zealand. You can definitely take 10 milligrams once a week. I mean, obviously, please do tell your own doctor if you're going to be doing that. I have patients who take folic acid every single day, and there's no real danger that I'm aware of overdose with folic acid, because it's actually a natural vitamin in your body anyway. It's just the levels are going to be impaired when you're taking methotrexate. So it's good to supplement.
Are voice issues, hoarse voice, croaky voice, quite common with RA?
Not that I'm aware of, but I think nothing is impossible when you have an autoimmune condition. How your autoimmune condition affects you will be different. Not in my experience. There are certain types of inflammatory arthritis which are linked to diseases that can actually cause inflammation quite a lot in the cartilage of your trachea and your voice box, but that wouldn't be classical rheumatoid. So no, not that I'm aware of.
And how long can we safely take methotrexate at 15 to 20 milligram per week post 10 or 20 or 30 years?
You can stay on it as long as you feel it's working and as long as your lab tests are fine. So I'm leaving it really deliberately open because, again, I've got some people who've been taking it for 25 years, maybe a bit longer, and they're completely fine. They haven't run into any organ damage or bad side effects. The key is that they're having monitoring. The key is that somebody's overseeing the fact that they're being prescribed that medication and somebody's overseeing their lab tests and checking in with them once in a while.
Is Sjogren's considered an inflammatory arthritis?
Well, technically, it's considered to be a connective tissue disease, and it does cause inflammatory arthritis, yes, or it can cause a type of arthritis that looks very much like rheumatoid.
After 10 years, my diagnosis of RA negative factor was changed to polyarthritis. What is this? I use methotrexate and leflunomide.
Oh gosh, terminology and language are just a minefield. And I'm really sorry about that. So there are lots of different terms, and I think we need to do better. I will say we in rheumatology need to do better at actually naming things and updating their names. So the example that I gave you about inflammatory arthritis, well, that could mean gout. You know, it's better to say autoimmune inflammatory arthritis for this talk. So polyarthritis, seronegative arthritis, seronegative inflammatory arthritis, undifferentiated inflammatory arthritis, they are all different labels which are alluding to the fact that the person thinks you've got some type of inflammatory arthritis, but it's not clearly defined. It's not clearly defined according to the classification criteria or the diagnostic criteria that we have, that we can clearly say, oh, yeah, this is rheumatoid, or yeah, this is psoriatic arthritis. And to be frank, this happens a lot. So initially, when you first start having symptoms, unless you've got really strong positive rheumatoid arthritis antibodies in your blood, it's very common to receive that sort of diagnosis that you've got a polyarthritis or a seronegative inflammatory or something inflammatory. And then as time goes on, the pattern of your symptoms starts to become more clear because you do need time. Time is really important for diagnosis in rheumatology. And then as time goes on, you might find that your label changes. It goes from, one to the other, like it's just happened in this person's case.
Do any of the drugs you mentioned cause crazy dreams? I'm on methotrexate, hydroxychloroquine, and leflunomide, and having very vivid dreams since the addition of leflunomide.
I don't know about leflunomide. I believe anything is possible with any medication. So possibly, but I have heard that with methotrexate.
Is there any link between RA and previous surgery, like spinal fusion or other surgeries where you have metal implants in the body? I think maybe in that question they mean, is there a link between onset of RA and previous surgery?
Yeah, so RA, like anything autoimmune, often kind of develops after something traumatic. So that might be a pregnancy, it might be surgery, major surgery. So I think it's more that rather than the specific metal stuff that they use inside your spine. There are some surgeries which are linked with the development of arthritis. So breast implants are a classic example. People with silicone breast implants can get a type of inflammatory arthritis that looks very similar to rheumatoid and also looks a bit like Sjogren's disease as well, but not metal that I'm aware of as a trigger for rheumatoid. It's more likely that it's the major surgery, the stress on the body.
So now says, my understanding is that during a flare-up, the patient should avoid manual therapy. In your experience, is this correct?
So if we mean manual therapy, where you're going to see a body worker and they're going to be palpating and doing stuff to your body, I think it's really hard to give an absolute black and white yes or no answer because it depends on your body worker. It depends on who's doing it. So manual therapy that you give yourself, for example, you could get a couple of massage balls and you could sort of give yourself a self-massage around your neck or around your shoulders without necessarily aggravating your flare. Depends which part of your body is flaring in. So I don't think it's an absolute no. I think, like everything, even with a flare, it's still important to keep moving. So maybe not necessarily moving the part that's really painful and swollen, but you could move other parts of the body, and you could do that yourself, or you could get a body worker to do it.
In regards to ankylosing spondylitis in general, when is it appropriate to escalate from simple treatments, e.g. silicosis as needed, or to the DMARDs biologics?
So in New Zealand, we've got to meet certain criteria in order to do that. And I know we'll talk a bit about this more on the next session, but there's certain criteria that pharmacs set. There's a reason why we can't give or offer biologics to everybody who's diagnosed with AS. So usually we recommend the exercise is actually the number one treatment. So movement truly is medicine for anybody with spinal ankylosing spondylitis. The daily movement, daily stretching, anti-inflammatories. Sometimes you might need to use drugs like methotrexate if you tend to get a lot of swelling in your joints and not just stiffness in your back. And then if all of that is not holding things the way it should, and you don't have a good quality of life, if you meet the criteria at that point, you would, go into a biologic.
Do people lose weight and muscle mass due to RA or due to methotrexate? This person says their blood tests have been normal for the last 8 years of being on methotrexate, but for the last 1 year, they have lost a lot of weight and become very thin.
My first question would be, does that person resistance train? Because if you are a certain age, I don't know. I mean, especially if you're a woman, and if you're a woman over the age of 40, you're going to lose muscle mass rapidly, regardless of whether you have got arthritis or not, just by virtue of being an older woman. And once you get into menopause, it's really going to drop off. So you need to be weight training as the main way to keep your muscle mass and ideally build your muscle mass. Rheumatoid or having any chronic arthritis definitely can lead to loss of muscle mass, mainly because people aren't moving. So if you don't move, unfortunately, and it's understandable why people don't move that much if they're in pain, but it's just the worst thing you can do for your muscles because they just atrophy really quickly. They waste away very quickly. That's something called sarcopenia. So yeah, resistance training, really important.
And I did, just on a side note, have someone reach out recently who was having some muscle loss, and she has started a really good muscle training program. And she has asked about creatine supplementation to help with that as well. And from what I saw, it looked like it was safe for people with rheumatoid arthritis, just as with the general population. So that could be another thing that may help with muscle mass whilst you're training. It must be whilst you're training.
Yeah, I think in general it probably is okay. There's a few people that we don't like to take creatine. So the people who've got bad kidneys, kidney doctors don't like them to take that. But generally I think it's okay. Or protein powders. Speaking personally, I use protein powders when I resistance train. Older woman, important to load your muscles.
Can a rheumatologist diagnose and provide cause or connection from severe infection, sepsis, and a close secondary infection 3 weeks later to PMR initial onset?
Can a rheumatologist diagnose infection and then leading to PMR?
So I think they mean, can the rheumatologist say for sure that there was for sure that there's a causal connection from the sepsis to the PMR onset 3 weeks later?
Short answer, no. No one can ever, this is my philosophy. I can't tell you for sure that it was the sepsis that triggered the polymyalgia to begin. There's no definitive test for that. But as I said, I really believe, and I see all the time, that when people go through profound stress, it is more likely to trigger the onset of something autoimmune. And autoimmunity is multifactorial, isn't it? So there's some genes that may well be in your body that are dormant, that haven't really done anything. And then there's the right combination of external triggers. It could be infection, it could be terrible stress, something in the environment, something in the atmosphere. We don't know. It could be smoking, it could be hormonal changes. We don't know what is the one trigger, but there's something that can then trigger your autoimmune genes, let's say, to kickstart and for you to develop that condition. So yes, infections are common triggers of autoimmune issues, but no one can tell you for 100% sure that that's what caused the PMR to develop in the first place.
Can RA affect the jaw joint?
Yes, the TMJ. Temporomandibular joint, yes.
Someone says, I just started hydroxychloroquine 9 days ago. I read the pamphlet about common side effects, but didn't go over the list of rare side effects. I noticed 5 days ago white noise in my ear when in bed, then again last night in bed. I didn't know that it was a side effect until you mentioned it tonight, that ringing in the ear is a rare symptom of taking it. Could the symptom of ringing in the ears have presented itself within 4 or 5 days of taking the medication? If so, is it serious enough that I should contact my rheumatologist to advise them of it?
Well, I think you should contact your rheumatologist, definitely, just to let them know that you've got that symptom, and they'll probably recommend that you go get a hearing test. I think, again, nothing's impossible, but if you've only been on it for 4 days, it might not be the medication, but I think it's important that your doctor knows, and then they can take appropriate action. And they might even just say, well, pause it, stop it temporarily, see what happens. Does the ringing noise go away? And then retrial it slowly at a lower dose and then see what happens. Does it come back again? But you do need to talk to your doctor.
If I'm taking methotrexate but still getting flares and also continuing fatigue, is the methotrexate working?
Hard to say, because you should definitely still expect, and I say this to everybody, that you should still expect to get flares of your arthritis, even if you're on lots of treatments, even if you're taking 2 or 3 tablets, or say you're on a biological, it's still entirely likely and possible that at some point you will have a flare. But the point is that when you do have a flare, it should be a lot less common. So it should be infrequent, and it should be a lot shorter. It shouldn't be a dragged out flare going on for weeks. And it shouldn't be happening too much. So if you're having the occasional flare and you still feel fatigued, your methotrexate may well be working. The way that you need to assess that is by, when you talk to your doctor or when you see your specialist nurse, they do a joint count and they look at your labs and they try to figure out how active is your disease. So your disease can be in a remission state, or it can be in a low disease activity state. And that means the methotrexate's working, even though you still feel fatigued. Fatigue, again, we could do a whole separate talk on fatigue. Fatigue is the most troublesome symptom for people with autoimmune, with inflammatory arthritis. And even if you have squashed all the inflammation with the most powerful drugs going, fatigue can still be there. And that's because it's more than just inflammation that drives fatigue.
Great, thank you. Well, that is all we have time for. You managed to answer 22 questions in that time.
Good.
So well done. Amazing. We had 212 people join us tonight. Thank you everyone so much for joining us tonight, and thank you for your thought-provoking questions. Make sure you catch us for part 2. And just to let you all know, yes, every single one of you who has registered will receive the recording of tonight. So you can look over Nikki's slides again at your leisure, and you can watch this webinar again with all the questions and answers as well. And also just want to thank Nikki so much for her time, and acknowledge all the passion and time that you give us. So thank you.
Thank you.